Hi, folks. Dr. Ditchek. It is Wednesday, August 5th, continuing with our educational forum that's been so successful, thank God. Going to talk today again. This is pre-peer review, but very important data that was released over the weekend by the Mayo Clinic. The Mayo Clinic, as most of you know, had been doing very robust antibody convalescent plasma studies on COVID patients during the peak of the crisis, both Mount Sinai here in New York and Mayo Clinic out in the Midwest. And the Mayo Clinic actually put on a very interesting webinar over the weekend. I reviewed the slides. I didn't have an opportunity to hear the webinar live, but there were some very interesting conclusions from it, which I think are very important for everybody to know about because it shows you historically how far we've come. So as all of you know, convalescent plasma are where antibodies recovered from individuals who have recovered from COVID-19. In other words, they were sick, they developed a very robust antibody response, and then they donated plasma. That plasma was then purified to the point where where antibodies could be retrieved. Remember, those are neutralizing antibodies that can actually kill virus. And that donated plasma was used to care for seriously sick COVID patients. As we've spoken about on this forum, during the peak of the crisis here in New York, plasma was being given only on a compassionate use basis primarily, and unfortunately it was given very late stage when people were already critically ill. In many cases it was given so late that it really didn't make any difference. So there was a restructuring of the convalescent plasma studies recently. And this study reflected an aggregation of over 3,000 hospitalized patients who were divided into several groups who received convalescent plasma. One of the groups received convalescent plasma within 3 days or less of diagnosis with COVID-19, and they received very high level of antibody plasma, in other words, plasma that had very high levels of anti-COVID antibodies in them, and the mortality rate went down to 6.5% at about 7 days after diagnosis. The second group that was looked at were individuals who received plasma that didn't have quite the higher amount of anti-COVID-19 antibodies or low levels of antibodies in that plasma. Those were given at 4 days or more after diagnosis, and their mortality rate after 7 days from diagnosis was about 13.5%. So in the individuals who got the very high concentration of antibodies in 3 days or less early in the course of the disease, they had a 6.5% mortality. In individuals who got the lower concentration of antibodies but 4 days or more after diagnosis, they had more than double the mortality rate of 13.3%. So in those two groups alone, it showed a 50% reduction in mortality. That is a very dramatic result from a scientific standpoint. At 30 days after diagnosis, when you combined all of the groups that got convalescent plasma, there was a 36% mortality reduction overall. So that's a very positive outcome. The FDA is looking very closely at this study. I believe that the FDA is within 2-3 weeks of making a decision, making it now standard of care to give convalescent plasma at the earliest point of hospitalization before waiting for a patient to deteriorate. I believe that's going to happen within the next 2 to 3 weeks if my guess is correct. It's just a guess. It's not anything more than that at this point. Historically, this is not the first time in history convalescent plasma has been used. In the pandemic of 1918, they were actually giving blood transfusions from recovered patients directly to critically ill victims of the Spanish flu between 1918 and 1920. That was a very crude form of giving quote-unquote convalescent plasma. They were doing it in the form of whole blood. They didn't have the ability to process plasma off of whole blood. However, in the 2014 Ebola outbreak in Africa, the scientists that were sent there from not only international organizations, but from teams from here in the United States, they were able to set up mobile hospitals in Africa, and they were giving significant amounts of convalescent plasma to Ebola victims with very good results back in 2014. So this is again reusing an old tool in our toolkit to help save lives. To date, over 50,000 people in the United States have received convalescent plasma. New studies, new randomized control, double-blinded studies are being carried out now to look at even more hospitalized patients to see if we can reproduce these results. But more importantly, there's actually a new study that's starting within the month, apparently, that will be looking at the use of convalescent plasma pre-hospitalization. In other words, when somebody is in a high-risk group and they are diagnosed with COVID, they'll be given immediate convalescent plasma before they reach that point of needing hospitalization. And that's the intention, and the working group I'm working with is focused very much on ambulatory treatment right now, treatments pre-hospital. In other words, how do we treat patients before they need hospitalization? And the convalescent plasma studies are one of the tools that we'll be looking at pre-hospitalization. Tomorrow, we're going to talk in more detail about the recent discussions of monoclonal antibodies. Currently, there's a large number of studies that are looking at successful early trials with extracting monoclonal antibodies from also recovered COVID patients. What are monoclonal antibodies? Those are when somebody gets an infection, the body produces hundreds of thousands of versions of antibodies in response to infection, but only a small number of those antibodies are actually useful to kill the actual virus or bacteria. So what many labs are doing, many researchers now are finding the best of those antibodies, extracting them and trying to reproduce them or stimulate them in larger numbers so they could be reinfused back into individuals. Those are called monoclonal antibodies. Now, why is that important? We've spoken about it on this forum. There's a concept called passive immunity. Active immunity is when we give a vaccine and you stimulate an immune response in the individual, they make their own antibodies, and then they can be defended against an infection. Passive immunity is when we give the actual monoclonal antibody to the individual. This strategy has been used in diseases like arthritis, lupus, or inflammatory bowel disease in the past by infusions. But here, what the researchers are talking about, and I think this is going to happen in the fall and winter, is giving somebody monoclonal antibody passive immunity who's in the high-risk group before a vaccine is available as a bridge until we can get to the vaccine. Now, the good news is that it probably works very well. The bad news is you probably only get about a month of immunity from doing infusion of monoclonal antibodies. So this is the new strategy that's being looked at pre-vaccine to protect those most vulnerable in our communities. I think we're going to sign off today. We had a number of positives over the last few days through our Sophia testing platform here in the office to show you the diversity. We've had positives in the last 48 hours from individuals who've traveled internationally. We've had positives from individuals who travel locally. And we had a positive yesterday, unfortunately, in a family that has an end-stage cancer patient living within their home. And actually two of the family members, I'm told, are positive within that home. So a very, very high-risk situation for that cancer patient because clearly they can't tolerate a COVID infection right now. But it points to the utility of the Sophia rapid antigen platform that we're using. This is a great tool that we now have in our office, and hopefully many other offices will be replicating this, because we can now tell people to isolate, to protect others. Every case we had so far that we've identified early, we've been able to give them instructions on isolation and quarantine so they didn't infect other people. And this is a very useful tool which will save lives come the fall and winter. I'm hopeful that we'll get more machines out into the communities and to the nursing homes in the near future. So we're going to call it a day for today. I hope everybody has a wonderful evening. Get some fresh air. Wear a mask when you go outside. We're going to talk about that over and over again. It's becoming more and more clear that we need to adopt universal use of masks now until a vaccine is available. That's our only prevention right now, and I'm encouraging everybody to do so. Have a great evening. Take care.